when they're getting the slides ready, at the outset, I would like to thank the scientific committee and the organizing committee for giving me this opportunity. And my talk for today is interpretation of abnormal thyroid function tests in children. This becomes very important in this thyroid test era, where thyroid function tests, TSH alone or in combination, is one of the most common tests done. Often they are done unnecessary, done for non-specific symptoms like weight gain, some hair loss, fatigue, etc., or on parents' demand. Clinical decision making becomes particularly difficult when the test results are borderline. And parents are very unhappy to hear that a TSH of 7 does not really explain the child's symptoms, resulting in a lot of overdiagnosis and overtreatment. However, decision making is even more difficult when the TFT does not make sense. So, in order to understand, in order to proceed further, we need to understand the basic thyroid physiology, which is absolutely important to order and correctly interpret the thyroid function test. I want you all to concentrate only on the left-hand side, which I have highlighted, which all of us are aware of the positive feedback effect of TSH on thyroid and the negative feedback effect of thyroid hormones on the pituitary. The rest of the slide we'll deal with later. So, looking at the basic test for identifying thyroid disorder, TSH is the most sensitive marker. And why is it so? Because there is a log linear relationship between TSH and free T4. That means a 10 to 15% decrease in free T4 causes a 100 to 200% increase in TSH. So translated into clinical terms, if the free T4 drops from 1 to 0.5 nanograms per deciliter, it raises the TSH from 0.5 to 50, whereas a TSH rise of 1 to 5 just reflects a very minuscule drop in free T4. This has been taken directly from Gurnall et al.'s publication. So we have very sensitive third generation immunometric TSH assays available with a high functional sensitivity. What about T4 and free T4 levels? Although TSH is the most sensitive marker, it is important to interpret the TSH level in relation to concomitant T4 levels. And it becomes absolutely important to diagnose subclinical hypothyroidism and to diagnose and monitor treatment in central hypothyroidism and thyrotoxicosis. What about free T4 versus total T4? We all know that the free or the unbound T4 actually represents the tissue thyroid hormone availability, and the levels of the thyroid hormone binding proteins can be affected in various conditions, which has an impact on the total T4 level. Should we test serum T3 routinely? We know that 80% of the T3 formed in target tissues is from the conversion of T4 to T3, and there is an increased conversion during hypothyroid state to maintain the T3 level until moderate to severe hypothyroidism occurs. Therefore, measurement of T3 is not useful to diagnose hypothyroidism. Having said that, serum T3 measurement is useful and absolutely imperative in certain clinical conditions, which I'll deal with later. So logically, based on the HPT axis, we can conclude that low thyroid hormone should result in elevated TSH, and an elevated thyroid hormone should result in suppressed TSH. Let's see what happens in the clinical scenarios, assuming assay is reliable and age-appropriate reference ranges have been used. Simple scenario, 5-year-old girl with mild TSH elevation. Now, if you just look at the numbers, we cannot take a decision on the treatment. We need to know the clinical scenario in which the thyroid function test has been ordered. For example, if this child is a known case of hypothyroidism on thyroxine replacement, the most likely cause for such a mild TSH elevation would be compliance issues, where there are several days of missed doses and additional dosing before the hospital effect. We know that TSH, because of its half-life, reflects the treatment over the past 4 to 6 weeks. And the management of this condition would be just counseling, and no dose increase is needed with a repeat TFT later on. Suppose this was done on a child with a congenital hypothyroidism on follow-up. and with a clinical euthyroid state. We are all aware of a mild hypothalamic pituitary resistance during infancy, but a small percentage of these children can have this mild TSH elevation continued on beyond childhood also. Suppose this was done on a healthy child, TFT was ordered as she was gaining weight and mother has hypothyroidism on a small dose of thyroxine, a very common scenario in our clinical situation. We would consider subclinical hypothyroidism, which is a biochemical diagnosis. Certainly, there are few factors for overt hypothyroidism, but my next speaker will elaborate on this, so I will not be talking more about this. And this condition needs reassurance to the parents and wait and watch. And we also need to be aware of common syndromes with mild TSH elevation representing a TSH resistance, the commonest being Down syndrome and pseudo-hypoparathyroidism. A word of caution, Down syndrome children can develop the various thyroid disorders at any point in their life and they need monitoring. Moving on to the next scenario, a low T4 free T4. As per the logical conclusion from the HPT axis, we should expect an elevated TSH, but there is an inappropriately low TSH suggestive of central hypothyroidism. Interpretation of this is not difficult, but this can only be identified if T4 is done along with TSH and completely missed if TSH is done alone. This has got major interpretation of this has got major implication on the further follow-up, because it is really important that we screen for other pituitary hormone deficiencies and we commence hydrocortisone if there is a concomitant ACTH deficiency before we start thyroxine. It has also got an impact on monitoring, because in central hypothyroidism, we monitor T4 for the adequacy of treatment. Another scenario, interpretation of thyroid function test during acute illness, what we call the non-thyroidal illness, previously known as sick euthyroid syndrome. So in acute illness, you have low or low normal T4 levels, but the most important is there's no compensatory TSH rise. Normally we do only T4 and TSH. We don't do any further tests at that point of time. So this may be related to the illness per se or drugs used during acute illness. I'm not going to elaborate on the mechanisms causing this, but it's important to remember that the TFT changes during non-thyroidal illness is considered protective and adaptive. However, there are some recent studies saying whether there is a component of peripheral adaptiveness and a central maladaptiveness, and some novel metabolic interventions have been proposed. And when they recover from the acute illness, although there is normalization of T4 and free T4, TSH may remain mildly elevated. So in a child who's critically ill, avoid doing TFT as much as possible unless you really suspect a thyroid disease. And it's important to repeat the thyroid function test if there is an abnormality 2 to 3 weeks or later after recovery. Very rarely, this can be have a diagnostic dilemma with true central hypothyroidism. Here, the T3 comes into picture. In non-thyroidal illness, the T3 is always low. In addition, central hypothyroidism can also have additional deficiencies like low cortisol level. A scenario which is not so common, but thyroid function test done for a healthy 5-year-old who has constipation. Borderline TSH level, depending on the lab which you're using, but definitely low T4 level. Thyroxine has been started. This resulted in a hypothyroid state with suppressed TSH and elevated FT4. And stopping medications brought back the euthyroid state except for persistently low T4 level, which is TBG, thyroid binding globulin deficiency. It could be congenital, very rare, but can be acquired in certain conditions. But most important thing to remember is this has got no metabolic effect and hence does not require treatment. Awareness of this is important to prevent unnecessary investigations and treatment. Moving on to the next simple scenario, elevated T4 and free T4 with markedly suppressed or unrecordable TSH, clearly thyrotoxic. But is that all that is needed for starting treatment? Just those numbers will not help us to start treatment, because based on the scenario, the diagnosis changes. It could be Graves, but it could also be subacute thyroiditis if there is associated fever, local pain and thyroid tenderness, because it's a transient phenomenon. Hashimoto's thyroiditis, the toxic phase of Hashimoto's. It could be McCune Albright based on all the other clinical findings. So just knowing the numbers and interpreting that is not enough, even in simple and straightforward thyroid function tests. If TSH is suppressed, it's important to remember, if there's an unrecordable TSH, but normal T4 and free T4 level, it's important to do T3 to confirm T3 toxicosis. Moving on, in the same hypothyroid condition, treated for Graves' disease and at follow-up at 9 months, just by looking at suppressed TSH, we cannot consider it an ongoing thyroid toxicosis because the concomitant T4 and free T4 is low, suggesting hypothyroidism, and this child needs thyroxine supplements. So in Graves' disease, TSH is not a good tool to monitor while on treatment because it takes several months before the TSH becomes recordable. Consumptive hypothyroidism, not so common condition. Why is it important? It's a plain and simple and straightforward primary hypothyroidism. Here the interpretation is not the problem. The problem is ongoing hypothyroidism despite large thyroxine doses, which is very alarming to the clinician. So the clinician will end up keeping on repeating the samples or sending to different labs, or even the parents may take the child to different centers for treatment. It is important to remember that in these conditions, the cause for the thyroid hormone deficiency is expression of type 3 deiodinase, which actually deactivates the T4, and as a result of which they need T3 in addition to thyroxine, T3 tablets in addition to thyroxine to achieve a euthyroid state. This is a clinical diagnosis, although the biochemical marker is elevated reverse T3. So the learning points from the slides as far as, even in simple and straightforward thyroid function test values, it's very important to take a good history and examine the child before you order TFT, before you interpret, and before you treat, because your treatment and the follow-up parameter varies with different scenario. Moving on, from simple to complex thyroid function tests, when it doesn't make sense. When it doesn't make sense is when the TSH and T4 do not reciprocate each other, means low thyroid hormones should cause an elevation of TSH and vice versa. So there is an unphysiological association, and all the results do not fit in with the clinical findings. A structured approach avoids incorrect diagnosis and inappropriate management in this condition, which is a combination of clinical, a complete thyroid function test panel including T3, and adjunct tests including genetic tests when needed. So here I would like you to focus on the target tissues. So beyond thyroid hormone production, there is so much involved at the target tissues regarding the thyroid hormone metabolism and how the thyroid hormone actually becomes available to the cells and becomes functional. So we all are aware of the deiodinases. It's important to remember that the three types of deiodinases, they are tissue specific. So, and in addition, the thyroid hormone receptor, there is alpha 1, beta 1 and beta 2. Once again, they are tissue specific. And we have this monocarboxylase transporter 8, which is specifically a T3 transporter in certain tissues, particularly hypothalamus. And we also know that the negative feedback what is given to the pituitary and hypothalamus is primarily mediated to the thyroid hormone receptor beta 2. So knowledge of this is very important because the pituitary is not able to sense that there is enough thyroid hormone or not, and because the receptors and the various deiodinases, everything is tissue specific, there may be hypothyroidism in some tissues while there is hyperthyroidism in some tissues. This results in this unphysiological association in the TFT and brings complications. So these are conditions where there is elevated free T4 and free T4 with non-suppressed TSH. Rare conditions, but it's important to remember two conditions particularly. One is resistance to TH, particularly the beta part because of the genetic mutation. A positive family history is there, and usually these children have goiter and is in a euthyroid state, but there can be tissue selective hypo and hyperthyroidism, sinus tachycardia and attention deficit disorder. And the close differential would be a TSH secreting pituitary adenoma. The metabolic picture is essentially the same, but MRI will help with the diagnosis. Selenoprotein deficiency, because selenoprotein is an important component of the deiodinases. So that can also result, and as you can see, one of the important biochemical markers there is high reverse T3. So this is what I meant by the complete TFT panel. We may have to do specific tests in conditions. Persistent T3 elevation, a well-known entity now, an X-linked MCT8 This is monocarboxylate transferase 8 deficiency. Here, the biochemical picture at diagnosis is that of central hypothyroidism, low free T4 with normal or mildly elevated TSH. On high doses, there's ongoing psychomotor delay, and eventually, when we look back, there is a persistent elevated T3, which is the most consistent biochemical abnormality. So this is a state of peripheral thyrotoxicosis with cerebral hypothyroidism, and treatment is with T3 analog, which is not available in India but can be made available from a center in Sweden, and few centers in India are actually treating, including CMC. So these are rare conditions, and why is it so? Interpretation of TFT may be difficult, but the correct diagnosis is important because we need to differ the monitoring parameter and adjust the things. So, for example, even though biochemically there is elevation of thyroid hormones, clinical hypothyroidism may be ongoing, may need to measure indices of peripheral thyroid hormone action like SHBG, and may need large doses for treatment, and is particularly important. There is a clinical hypothyroidism ongoing, so just looking at the biochemical parameters of hyperthyroidism, we should not treat with antithyroid drugs. And in children with developmental delay and multisystem manifestations, of course, optimal early treatment and correct doses is important, but we know that there are several genes which are involved with multisystem involvement, and knowledge of this is really important because genetic diagnosis is possible. When TFT is unnecessary, I really want to put up this slide because non-specific symptoms, please do not order a TFT. I am not going to read through this because most of us know the reasons why we order. In summary, we have to ensure standardized assay and age-appropriate reference range. And if there is one take-home message, this is the second point here. You would have noticed that there is no algorithm or tables in this chart because I personally feel we should individualize the ordering, interpretation, and treatment based on the history and physical examination. And the algorithm which we should actually be thinking of is the slide on the HPT physiology and the target tissues. Interpret TSH in relation to the concomitant T4 and free T4 levels, especially when you start treatment. T3 alone is not useful. T3 is not useful to diagnose hypothyroidism, and unphysiological association and TFT, different from clinical picture, warrants detailed evaluation for correct interpretation and etiology. Thank you.